So as I say, I'm one of the national clinical leads in service improvement, have been since 2002. So part of my job is working for NHS Improvement. I would urge you all to go and have a look on the NHS Improvement website. So you just Google radiology improvement to get you there, or use that website. Have a look at what's going on. And there are lots of case studies of improvement of radiology all around the country. And stroke and TIA imaging has been one of the big work streams for our team for the last couple of years. My main job is working as a radiologist in Torbay Hospital, which is in Torquay, famous for not many things. Fawlty Tower is one of them, having one of the highest teenage pregnancy rates in the country, but also quite a sizable elderly population, so we have lots of strokes and TIAs. We're a sort of average sized DGA catchment population of about 280,000, but with quite a few tourists in the tourist season. And as we've heard, particularly this morning and from a lot of the speakers, that it's not just about stroke, is it? We're under pressure from all sides, and all the targets, everything we have to do as quickly as we can, to the financial pressures and so on. And our stroke physicians coming to us saying we've got to be getting up in the middle of the night and doing these scans within 5 minutes is just the final straw, isn't it? So I'm not going to talk too much about stroke. This is a bit more of a general talk about what we do in Torbay, and I'm happy to take questions or be interrupted and talk about general service improvement as well. One of the nice things about my role is that I get to go around and see what people are doing around, and some of that has helped me go back to my department and implement changes, and also means that I get to know how different places work, because most of us, we settle into a department and then that's basically all we experience, isn't it? We just know what it's like where we work. So I can talk about anything you want really, but I'm going to just really go through briefly about how we work in Torbay and how I think it helps us organise things fairly efficiently. Mainly about what we call our 7-day working, and then about more recent changes to how we as radiologists work and the implications on how that works for stroke. So we don't have proper 7-day radiology as in the Saturday and Sundays are not exactly the same as the Mondays and Tuesdays, for example, but we're closer to it than many departments are. This all came about 13, 14 years ago, and there was the usual problem that every hospital has with the winter pressures, bed crises, elective work being cancelled. And a lot of modelling was done, and it was determined that we needed to have a 10% reduction in emergency admissions and reduce the length of stay by an average of 1 day. And this required lots of changes, particularly setting up an effective emergency assessment unit, but also changes to radiology. And this is where it all started, really. And so since then, we have had fixed consultant radiologist sessions on Saturdays and Sundays. So we have a consultant in all day Saturday and all day Sunday as a fixed part of their job plans, rather than just emergency on call work. And they've been supported by an extra radiologist support worker, porter on the Saturday morning for the ultrasound list. And we used to have a secretary, but now with voice recognition we don't need that. So what does the radiologist who's in the weekend do? On the Saturday mornings, we do an ultrasound list, so they clear all the inpatient ultrasounds that are hanging over from Friday afternoon, Friday evening, any admissions overnight that need ultrasound. Over the whole weekend, they report the A&E and inpatient plain films, which since we converted to PACS a few years ago has been much easier to organise, of course. They deal with any emergencies, as they would have done anyway if they'd been on call from home. But they also clear all the non-emergency inpatient stuff. Certainly all the CT and ultrasound, less easy once you've done the Saturday morning list because that's manned with a porter, but the sort of urgent ultrasounds get done as well. And from the beginning it was clear that even that was not enough work to justify one consultant working flat out, so we booked some outpatient CT as well. But it's not like a full working day's weekend CT churning through hundreds of outpatients, but there is some outpatient work being done as well. And it works. The modelling targets were met. I mean, it's not just radiology, it's the changes to the way the hospital is running as well. It's good for the patients. They're not sat around, particularly the inpatients, they're not sat around for 3 days waiting for their scan over the weekend for the ones that aren't really urgent. The clinicians in the hospital think it's fantastic service. And a lot of the patients like coming at the weekend if they're given the option. It also smooths out the work. We heard this morning people talking about the Monday morning catch up until 3 o'clock and you're clearing all the chaos. Our Monday morning ultrasound list has no inpatient slots on it at all, because there's no point. And the Friday afternoon list is no longer the nightmare list that you give to the new junior consultant when they've arrived. Because people, the ones that come in the Friday afternoon have done on Saturday morning cannot do it. It was quickly realised that doing all this work at the weekend, in terms of speeding through the throughput and the sorting out the patients, didn't make any difference unless there was a senior decision maker to act upon the result of the imaging. So within about 6 months, it actually changed how the physicians and surgeons were working, and they started having fixed ward rounds as part of their job now. So we've sort of evolved into the whole hospital pretty much doing weekend working of some form or another. And you need that. There's no point doing the test if no one's going to act upon it. So how did that help us with the stroke pathway? Well, when the stroke physicians first came to us saying we want to do thrombolysis and we want you to be able to offer us a CT within 5 minutes whenever we want it, we all just said, well, that's ridiculous, and stroke's a clinical diagnosis anyway, why do you want CT? It's a waste of time. So we came from the old mindset of how we were brought up that you don't need to even to image stroke, but they came to us and showed us the evidence, and just as we've heard this morning, actually the evidence is good, and it's one of those things where we are going to make a difference to the patient, unlike an awful lot of the stuff that we do just because we've always done it. And so we started off saying, yes, we can probably offer that 9 to 5, Monday to Friday. And we quickly realised actually the numbers are pretty small, and we could easily cope with just squeezing in as urgent cases. So that made it very easy for us to extend that to doing that 9 to 5, Monday to Sunday, because we were already working at the weekend. So this whole thing we've heard today about, we want to set up a weekend service for TIAs or for stroke, but the numbers don't justify it, or we want to do it for X, Y, or Z. It really, that argument disappears if you say, well, actually, you want to work at the weekends for the whole service. And the fact that it's 2 or 3 TIA patients or two or 3 query thrombolysis patients is just a small part of the whole service running every weekend. So once we were doing that, we realised the numbers weren't big, and it was very easy to extend it to 24/7. So we've been doing that for a long time now, offering CT for thrombolysis any time of the day. And of course, we've heard about the requirement to get all your stroke patients scanned, even the non-urgent ones, within 24 hours. It makes it extremely easy for us to do that. We just slot it in on the weekend as per normal, because we've got the staff there. So just more general rather than the 7-day working, what about our ways of working? Just some more ideas about how we're probably slightly different from some departments. We have done an awful lot of the sort of service redesign, the process mapping and the capacity and demand work. And then when PACS came in September 2006, I particularly saw it as a way of trying to solve some of those final things that we hadn't got cracked, like particularly the plain film reporting. I felt PACS was not just an electronic way of doing the same thing. It was an opportunity for us to change how we worked as radiologists. So, what are the most important things that we now do? Our radiologists no longer have their own CT or MRI lists. So there was variability as to how many patients could be pushed through a CT or MR list depending on which consultant was running it and how they wanted to control it. And that's not a very efficient way of running a service. Also, the booking. You could only book an ankle MRI onto one of the MSK radiologist lists, for example. And so if they're away, there aren't enough of them, the backlogs develop and you're segmenting your different queues. So we no longer have our own MRI and CT list. They're all just run to protocol. And of all the MRI and CT is allocated to make sure it all gets done. And it's allocated by alphabet. So the specialist stuff goes to the specialist radiologist, but all the general stuff, body CT, lumbar spine MRI, what have you, go by alphabet. So we look at who's here each week and see how many sessions each radiologist has, what sort of sessions they're doing. So if you have lots of hands-on work, like an interventionist, you get a smaller share. If you don't have much hands-on work, you get a bigger share. And we count out the number of pages in our local phone book to divide up the local population by their surname by a number of pages. So on the front page of our RIS, our CRIS system, it says this week letter A, B, C goes to me. So if your name is Brown, you have a body CT, it comes to me. We use VR, so there's none of the delay of dictating and it being typed up and verified. And the other thing we have, because we've separated the radiologists from the CT and MR list, we now, every session we have a nominated inpatient report, and that's all they do for that session. And they don't even get told as to what CTs are needed or get discussed with them. They just report what comes out, so they're not being interrupted at all. And we have a troubleshooter, so that is the person who is getting interrupted. So it's a nominated person who deals with all the queries. We also have flexible rotors, so we have to always cover those sessions. And I don't know what I'm going to be doing on a Tuesday afternoon, week to week. We cover what needs to be covered and flex around that. So the troubleshooting, we got the idea from the gastroenterologist. They have a gastroenterologist of the day phone, a mobile phone, the God phone, of course they like to call it. And ours is the radiologist of the day, the Rod phone. We haven't persuaded the surgeons to have a Sod phone yet. And it's a bit of a pain in the neck session, because you get lots of interruptions, but it means that when you're not the troubleshooter, you can walk out of your office down the corridor and not have to run in the opposite direction when you see an F1 or F2. The clinicians think it's fantastic. They know where they're going to go. It's written on the front of the department. Troubleshoot for the morning is Dr. So-and-so. They're in this office, and they've got the mobile, so they know who to go to. The radiologist level as well is all controlled as to what's coming through. And the main reason for doing it was to reduce the interruption, so that we could all just get on and do the work when we're supposed to. Now, some radiologists really don't like that concept. They are important, they like to feel important, they like to have things discussed with them. And the specialist stuff still does come to you when you're not troubleshooter. I'm an MSK and vascular interventional radiologist, and often the troubleshooter will say, this is a drainage needs to go and speak to Dr. Seymour. That's fine, but I don't get all of the, can you do these 3 CTs this morning, please, because someone else has dealt with that. And so I'm not being taken away from my job as a clinical advisor, but it's just the appropriate stuff to do. And it's a bit of a mindset. You can either see it as a gatekeeper role or as trying to help people. And you can imagine different radiologists have different perspectives. So did it work? Well, this shows just when we implemented the change towards the end of 2006, the difference between the purple and the blue bars is the total number of exams we're doing being performed and those being reported. So there was a gap, and that was mainly plain films that we just weren't reporting. And the yellow line is the number of exams unreported, which drops from thousands to none. And the blue line is the auto report, so it's proving that we didn't do it just by saying we're not going to report these, you report it yourself. So that the ones we don't report are the orthopaedic, fracture clinic and dental films. We report everything else. So we have no backlog reporting at all. And the vast majority of inpatient studies are reported the same working day. That includes the weekends, so that the small minority that aren't are the ones that are done sort of between 6 in the evening and midnight. They're reported the next day. We don't write in the patient's notes even on the ultrasound list because everything's just straight on to quiz and verified. And there's none of this phoning down to get results and things. If I'm troubleshooting and someone comes to me and saying, there's a CT body scan that was done half an hour ago, there's no results on CRIS, can you have a look at it? I'll say, no, there is an inpatient reporter, I can guarantee they will report it within the next half an hour. So what about MRI? Well, we've got one magnet. It was a relatively recent replacement, 2.5, 3 years old. And so the previous scanner, we couldn't do diffusion weighted imaging, we can now. We're running the scanner 8 to 8, 7 days a week, and it's still not enough. So we do have an additional mobile scanner 2 or 3 times a month as well, because we just don't have enough capacity because the demand's gone up, as we've heard this morning. And that's despite doing limited sequences wherever possible. So our standard lead protocol, for example, is 2 sequences only, so coronal and sagittal PD FACSAT. Our standard lumbar spine is 3 sequences, so we're pretty minimalist. And so all of this is on supervised runs of protocol, so we don't have radiologists interfere. And the reporting is all allocated, so there's no backlog. So how are we going to cope with the requiring to do the MRI for steroids? We've heard we should be doing them, and CT is a waste of time. So having spoken at this meeting 3 years ago and heard some other people talking, I thought, well, we really should be doing this limited MRI for TIA. And so we've been doing it for over a couple of years, one-stop service, so just the 3 named stroke physicians can refer for this. When I first tried to sell this to my colleagues, the radiologists were saying, well, we're already flat out, we can't do it anymore, and the radiographers in the MRI were saying, well, how on earth can we do it? We can't carve out slots. And I said, I don't think you need to carve out slots. What we're trying to do is just, it's only going to be 1 or 2 a day. The patient will just come round from the stroke clinic and just sit there. It's a 5-minute scan, and in a gap, just stop them. And that's what happens. So we haven't even carved out slots. And in the odd occasion when there really isn't room to squeeze them in between patients, they get told to come back the next day, first thing in the morning. And we've heard earlier about limited study with 4 sequences. Our limited study is 2 sequences. So we do axial T2 weighted and axial diffusion weighted, and that's it. And less than 5% end up coming back for another study if it's in a query tumour or MS or something. It's just answering that question: is there diffusion weighted abnormalities, vascular or not? And as I say, when I was trying to persuade my colleagues to do this, I was saying, well, at the moment what we're doing is we're giving these patients an appointment, and they're coming back in between 4 and 6 weeks' time for a scan that is of no value whatsoever, because the DWI changes will have gone. So we're doing something that's filling up a valuable slot, and our value to our clinical colleagues and the patient is 0. Wouldn't you rather be doing it the same day when it's useful? Actually makes a difference. There's evidence that supports it. And it's actually releasing that slot that they would have filled up 4 or 5 weeks' time. And if you think of it that way, it actually makes sense what we should all do. What else do we do that's a bit different from other places? Well, may or may not be different. We have a call centre, so all our outpatients book by phoning up and agreeing appointments, so we fill up our slots very effectively. We don't have DNAs and so on. We're one of the relatively unusual DGHs that manages to have an interventional radiology on-call service. Happy to talk about that if you wish. And as I say, go and have a look on the improvement website, see what else is going on out there. Thank you.